How are you all? Yeah, class has started sharp at 6 p.m. Okay, good evening to everyone. How are you all? I hope you all are. Yeah, I am good. I am very good. And yes, ready for another rocking session of physiology. After physio, we'll do the other subject. Okay. And yes, we are, yeah, sure, Devansh. Don't worry. Okay. I will be there. I'm just telling you, be positive, be sincere, because we are having everything perfect and we are planning to do everything possible to help you all. Okay. So don't worry. So teaching also, and yes, support also, everything with you people. So I want you all to give your best. Okay. And I want everyone to get very good score and the rank in the exam. Sure. Let's continue. So yesterday we were doing, I think we have done half of the file till page number 12. Now we'll do the remaining pages. So I'll start in 2 minutes. Okay. Let's discuss till then what is happening in your life. So I hope you all are doing well. You all are studying properly and everything is, yeah, my voice is already, with you people. Don't worry. So we'll be planning and doing everything. Just, yes. Remember, we have to do both. We have to study also and we have to, yes, get our rights, because there could not be discrimination at any level, because that is not good. Okay. Chalo. So already you know what's happening in NEET UG, exam. This very unexpected one. It's like 67 people getting 720 marks is like impossible, because earlier they will be having 1 or 2% getting full marks. Now 67, statistically it is impossible. That's the main thing. Okay. Chalo. So please join in. We are starting the class. Yeah. Yeah, already I've taken a PYQ session. Okay, you can watch it there. Okay, Raghuvandeep, I've already taken the, I'll share the link. Okay, but it is there. Okay, that's what I'm saying. Na? Yeah, one of them failed here. There's so many discrepancy. Okay, then they are giving grace mark. Why don't they give grace marks in NEET PG and FMG exam? Why grace mark only NEET UG, which is a competitive exam? Even single mark can change your rank by lakhs. How can you give grace marks here? It's a mockery. Okay, clear? So I don't know how can they give grace mark something. Chalo. So we'll be starting with CVS now. 1 second. Yeah. So basically remember, heart, the pacemaker is SA node, which is in the right atria near superior vena cava. Right atria. Right one. So right atria, superior vena cava junction contain our, yes, what structure? The pacemaker, SA node. Okay. Yeah, please don't discuss negative things. Okay, it's a very sad thing which is happening in our country, that nothing is now trustworthy but except EVM. People trust EVM because of the result. If the result would have been something else, they would have blamed the EVM. So at least EVMs are working, but again, other things are not working in this country properly. Okay, there was a major fire in I think some substation, and there was major parts of Delhi without electricity. Very hot also in Delhi. So things are becoming very difficult. Okay, now let's start. The pacemaker is SA node, which is having the highest frequency. So why the SA node of the pacemaker? Highest frequency. Second, it make automatic action potentials due to phase 4 pacemaker potential. What happens in pacemaker potential? Remember, phase 0 is depolarization. It is due to calcium channel, which cause the depolarization. Phase 3 is repolarization, which is caused by potassium. So potassium causes our, this is calcium, this is potassium. Now phase 4 will make the membrane go till the level of the new AP, and we get a new AP genesis. And now what occurs? Another AP will start. So this is new AP. And then again will membrane will. So what is this new AP generated by? Phase 4. So phase 4 create new action potential. What are the reason of phase 4? Basically it's early closure of the potassium channel, plus there is a funny or leaky sodium channel, plus calcium T channel, which is transient currents, okay, and this causes the membrane to reach firing level and trigger new AP. So they trigger new AP. Okay, so that is how it will work. So we get a new AP, okay, whereas in cardiac muscle there is no phase 4 or pacemaker potential. Now in cardiac muscle AP, so let's see cardiac muscle AP, there is depolarization, which is by sodium. So phase 0 depolarization, it is by sodium, not calcium. Phase 1 is our early re, and this early re is phase 1. I'll write it here. So this is early repolarization. It is due to potassium which is going out. So phase 1 is potassium going out. Phase 3 is again potassium going out. This is a late repolarization. It's a late repolarization. Phase 4 is RMP. RMP is 4, phase 4. And phase 2 is the plateau phase, which is due to calcium channel. So I'll write it here. So calcium channel create our phase 2 plateau. Okay, phase 2 calcium channel. Okay, calcium L channel. This create the plateau phase. What is the benefit of plateau phase? It increases refractory period. So there's a increased refractory period, which protect the heart from arrhythmia, abnormal contraction, tetanic contraction. So increase refractory period. Okay, which channel? Calcium L channel. Calcium L channel. So which channel? Calcium L channel is there. Okay. Now let's see the conducting pathway. So the impulses produced by SA node goes to AV node. AV node then send it to the bundle of His, then bundle branches, and then the Purkinje. Purkinje will give to the ventricle. So this is the pathway, and the current can go from left side to the right side through the internodal pathways also. Example, it is Bachmann's, Thorel and Wenckebach. They allow the currents to pass to other side as well as to the AV node. Okay, AV node then send the currents to the bundle of His. From there it goes to right and left bundle branches. The left will give fascicles, anterior, posterior. Ultimately, they give Purkinje fiber, which supply the ventricles, and ventricle then contract to pump the blood out. Okay. ECG, we already know what happens. First question they ask you is, what is the Purkinje fiber? Their maximum gap junction are seen. That is why they have the fastest speed. ये question था आपका. Maximum gap junction, Purkinje, fastest speed. And where is the speed? Worst or very low? So speed is very low, very less in which area? Speed. It is less in the AV node. So AV node speed is very low. So AV node speed is slowest. And it therefore cause something called as the AV delay. What is it called as? AV delay is the case. Fine. So AV delay. Okay. Speed is slowest around 0.05. Purkinje speed is fastest 4 meter per second. So 4 meter per second. Okay. So write the speed here. It is 0.05 meter per second. Are you clear? Chalo. Next question. What is the ECG changes? So this is a P wave. We discussed that in medicine class already. So P wave is due to depolarization. QRS is due to the ventricular depolarization, and T wave is due to repolarization of the ventricle. Okay. Now cardiac cycle. So I'll discuss cardiac cycle in my way. Okay. So cardiac cycle is 0.8 seconds. So approximately 0.8 second. two parts, systole and diastole. S1, S2 is systole. The two parts are isovolumetric contraction. In isovolumetric contraction, that is S1, we have the, yes, contraction is there, but AV valves are closed. That's why volume remains same. Volume is same. Then there is second part, that is your ejection part. So here Semler valve open, ejection occurs. So volume same, now ejection. Now after the ejection is over, what closes? The Semler close. So that called the S2 sound. So S2 is due to semilunar closure. Okay, semilunar closure. Now as the valve are closed, the volume remain the same. That is called as volume is same, but ventricles are relaxing. Volume same, relax. Okay, ventricles are relaxing. Okay, and now the filling occur. Now the what open? The, yes, the MV open, MVTV, mitral tricuspid, and filling occur. So now filling occur. And filling occur. Okay, clear? Filling will occur, and atria causes late filling. So atria causes late filling. So early filling is by gravity. It causes late ventricular filling. Late ventricular filling. This is early filling. And then when the ventricle contract, the MVTV close. MVTV close. This causes S1 sound. Are you clear? So that is how the cardiac cycle is there. Okay. So S1, S2 is systole, S2, S1 is diastole. What happens in S1? There's a closure of MV. This is MV. Sorry. This is TV and MV. They will close. TV, MV close. Okay. That is isovolumetric contraction. Pressure will increase. This pressure open the aortic and pulmonary. This is aortic valve AV. This is pulmonary PV. So aortic and pulmonary valve open, ejection occur into them. Then when the ejection is over, the valves are closed. So valves will close. This is closed now. So can you see the valves are closed? It's not simple, but understand. So valves are closed. As the valves are closed, the volume remains same, called as isovolumetric relaxation. Then there is again MVTV open, and the filling will occur. So this is TV, MV opening, and causes the filling. So this is the filling phase. I'll make with red. So this is the filling phase. Filling. 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 Are you clear? So filling phase is going on. Clear? So let me write it again here. Understand. So what is MVTV closure is? It is our what sound? It is S1 sound. Okay. So S1 sound is caused by closure of what? Closure of MV and TV. Now the period is isovolumetric contraction, then aortic valve open, ejection occur, then aortic valve close. So that is your closure. So I'll just give the color. So this is AV closure. As the AV close, ejection is over, and now you are relaxing. Now you are relaxing. This is diastole. What is the first period? Isovolumetric relaxation. Now the mitral valve will open. So what will open? Mitral valve, and there is a filling. Filling will have two parts, early and late. Okay, early and late. Then at S1 it will end. So when will it end? At S1 it will end. What are the two parts of filling? Early filling, late filling. Early causes S3 sound, late causes S4 sound. And at S1 again the valve is closed. So that is how our entire cardiac cycle plays. I hope it's clear. Now let's discuss the pressure changes during cardiac cycle. So pressure changes are as follows. So left atria pressure is 5 to 10 mmHg, or the also called as pulmonary capillary wedge pressure. Why? Because the blood from pulmonary capillary and vein goes to left atria. Reason is pulmonary capillaries and veins drain into left atria. That's why left atria pressure is pulmonary capillary wedge pressure. Okay, given by pulmonary capillary wedge pressure. Right atria pressure is given the name central venous pressure, which is around 0 to 5 mmHg or 0 to 8 centimeter H2O. Reason? The reason is simple. The blood which return from the body, it goes to right atria. That's why right atria indicate our which pressure? Central venous pressure. So central venous pressure. Whereas the right ventricle and left ventricle pressure is very high in systole, 120, 25 in right ventricle, but 0 in diastole. This is systole, diastole. 0 in diastole as ventricle relax so that filling occur, and filling occur when the pressure is low. If the pressure is high, you cannot put the blood from atria to ventricle. The pressure should be low and filling occur. Are you clear? So filling will occur in this case. Are you clear? Next is jugular venous pressure. So first question, it is from the internal jugular vein and show right atria changes. So what it shows? Right atria changes. So first question, when right atria contract, it give you the A wave. Okay, so A is atrial contraction. Then when the right ventricle relax, it give you C. So sorry, contract, it give you C. When atria relax, it give you X. So remember mnemonic, when problems in your life become your X problem, X, you should relax. So remember, X, relax. Okay, X is relax. So remember, X is relax. So when should you relax? When problem is there or gone. So problem gone, you relax. So that is the story in this case. Okay, now when the atria is filled, it is vena cava which are filling. So V wave is there. So the origin of V wave, so V wave originate because of the filling of the atria. And finally, when atria empty, tricuspid open, ventricle fill, that give the Y descent. So Y caused by? It is caused by tricuspid opening. Okay. Now let's see the volume changes. So what are the volumes? First is EDV. What is EDV? And diastolic volume. It is the blood filled in ventricle during diastole. It's called as what? EDV. Descent means decreased pressure. Yeah, descent means decreased pressure. Okay. So what is the normal volume which is filled in the ventricle? It is 120 to 130 ml. And it depends on what? Venous return. And remember, if EDV increase, it will put more load on ventricle even before the contraction. So that is why it is putting more burden, more load. Okay. Also called as what? Preload. Also called as preload. Okay. Next question. How much blood you pump out in one contraction is called as stroke volume. So 70 to 80 ml. Okay. Don't worry, Dr. Ioniza. Okay. You will pass. Okay. Just be positive. There's no substitute to hard work. Okay. Always keep improving yourself. Everyone, every time, they should improve. If you're not improving, you are going to, fall behind others. Clear? Like cricketers, or even, like doctors, we keep updating our skill. That's why AI is not going to replace us. Is AI will update, but a human is more adaptable. We adapt much better. A machine cannot adapt as easily as us. Reason, humans always aim for survival. Machine has no survival instinct. उसे क्या पड़ी है, जिंदा रहे, मर जाए, इलेक्ट्रिसिटी आ रही है. हमारे लिए सर्वाइवल इज द की. दैट इज वाई जब बात आती है सर्वाइवल की तो हमें कोई रिप्लेस नहीं कर सकता. So that is more than sufficient for you to study and pass. Okay. Now, what are the percentage of blood pumped called as? Yes. Yeah, it's more than sufficient. Okay. So many people have passed just using the Q bank and race session. It cover more than 60% of any possible question which will come in any exam. 60% का promise है, 60%. Okay. And 60% is sufficient to not just pass the exam, but also get a good rank in the NEET PG. Okay. Next question. What is the percentage ejection fraction formula? Stroke volume by EDV into 100. And what is ESV and systolic? It is the blood left after systolic ejection. Yeah, after systole, normal is 40-50. Formula is EDV minus stroke volume. Let me now teach you. Understand what is volume filled called as? Volume filled, it is EDV. Let's say 120 ml. 120. 20. What is the volume pumped called as? It is stroke volume, 80 ml. What is the volume left? It is ESV. It is 40 ml. What is percentage pumped? Ejection fraction. Formula SV by EDV into 100. Okay. So SV by EDV into 100. Okay. Next question. Thank you very much, Dr. ABC. Okay. Chal. Now let's move. Okay. Next is we'll discuss cardiac output. What is cardiac output? It is the amount of blood pumped by each ventricle per minute. तो याद करना output per beat is stroke volume per minute. So that's why formula is stroke volume into heart rate give you our cardiac output. Now, how do you estimate the cardiac output? We do echocardiography, then we can do dye dilution method, then we have the thermo dilution method. Also, we can use simple formula stroke volume into heart rate. So remember, they don't ask you the exact detail. Names are important. Dye dilution thermo. Here we use the formula of the amount of dye, then the concentration to calculate the cardiac output. Now, during exercise or running or physical activity, the cardiac output increases. Like I'm running. Why am I running? Maybe running away from a dog, but you should not run after dog. Reason? No, not after or away from dog. Reason? The dog will run faster. So कोई फायदा नहीं है. Rather we can confront. हाँ, if it's a rabid mad dog, फिर तो बेटा भाग लो. Next question. 20 to 25 liter per minute. So 20 to 25 liter per minute. What is it called? As cardiac reserve. Okay. क्या confusing है इसमें बच्चा? There's nothing confusing here. Volume filled EDV, volume pump stroke volume left after pumping is ESV, percentage ejection fraction, and in exercise cardiac output increase. What is cardiac output? Blood pump per minute. Easy तो है, इसमें तो कुछ है ही नहीं. Okay, and methods obviously they are used to measure the volumes. Okay, now how do you increase cardiac output? So increase cardiac output or stroke volume is by first is Frank-Starling law. What did it say? More you fill, more you will pump. Like example, if you do exercise or give IV fluids, it causes increase EDV volume and that increase the stroke volume and cardiac output. Let me show you by making a fresh curve. Have a look. See. इसको देखो. Okay. Let's say this is our stroke volume. This is EDV. This is Frank-Starling curve. Okay. So let's say EDV is 120 ml and it gives us stroke volume 80 ml. Okay, doctor. See, if you increase the EDV to 130 ml, we will get a bigger stroke volume, 90 ml. Okay. So what is happening? As the EDV increase, there is also what? Increased stroke volume. Done. This is Frank-Starling law. Understood? So more you give the blood to the heart, more you fill, more you pump. This is called as Frank-Starling law. Now can you shift the good evening Dr. Ved Prakash. Now if you give a drug which causes the graph to shift to left side, so this is the left shift. So in left shift, what happens? There's an increased stroke volume at same EDV. See, this is called as left shift or inotropic effect. So the other name, positive inotropic effect. So what is inotropic effect? It is increased contraction because of more calcium ion. क्या बोलते हैं इसको? Inotropic effect. Okay. So let's have a look. Okay. First is this is the curve and that is how we are seeing. So are you clear? So inotropic effect is there. So inotropic effect. Next question. Okay. So what are the main mechanism? Calcium. So mainly when you increase the calcium ions, it causes more contraction. This is called as inotropic effect. What are the example? Example of inotropic effects are catecholamine, epinephrine, norepinephrine, dobutamine. They uses beta 1, increase the calcium, and calcium cause contraction. Also digoxin, digitoxin, they increase calcium by blocking sodium potassium pump. So if you block sodium potassium pump, again it causes sodium to increase, then exchange with calcium, so ultimately calcium increase. So remember, in failure there is a right shift, left shift, right shift, and left shift is inotropic. So you can write it here, right shift in failure. So right shift occur in the failure and left shift occur in other case. So are you clear? Now beta 1 sympathetic, what actions it cause? It increase the heart rate, that is called as chronotropic effect. Remember chrono, इसी में आपका हिंट है, देखो HR. So chrono में C हटाओगे तो क्या आएगा? HR आता है, heart rate. You can remember C, increase heart rate. Ino is contraction. So ino is contraction. I told you ion. Conduction, duction is dromo, like drones. Drones go slow or fast? Drone उड़ के आता है ना, fast. So drone is speed. So speed is conduction. And if you are very excited, you take a bath to get ready. So excitement में ऐसा bath लो कि मजा आ जाए, ठीक है? Bath is exciting. So excitement is bath. Yes. Right shift is failure, ठीक है? Now what are the factors which affect our venous return? Okay. First is our gravity. So when you are standing, the return is poor. So that's why decrease VR in standing. Any example? Yes. Example 15th August or 26th January. Remember in school you are asked to stand in the assembly, and when you are standing your venous return decrease, which can cause decrease EDV, stroke volume, and even fainting can occur. So that's why syncope can occur, and PDF is in the description. So click the description, there will be a Google Drive link, click that, the PDF is there. So now in the school time when you faint, okay, what happened? Who goes to the site of fainting first? कौन पहुंच जाता है उस जगह पे सबसे पहले? तो सबसे पहले कौन पहुंचता है? हमारे PT वाले मास्टर जी. Okay, so PT teacher. Now all PT teacher, whatever school, they are similar. Let me show you. So they are always wearing track suit. तो क्या पहनते हैं? ये ट्रैक सूट, ठीक है, ट्रैक सूट, ठीक है. एंड दे हैव, देखो विसल, गले में क्या होती है? हमेशा एक घंटी लटक रही होती है, ठीक है. पीटी वाले मास्टर जी, ये कोई और मास्टर जी ना खोलो. फिर और क्या करते हैं? ऑलवेज ही इज इन द स्पोर्ट्स शू, एंड व्हेन ही गोज एंड ही सेड टुडे किड दे डोंट हैव एनी स्टेमिना, कांट इवन स्टैंड फॉर 2 minutes, वी आर स्टैंडिंग सिंस मॉर्निंग सर. एंड देन his classical reply, they don't eat anything properly, low glucose. In school time there was only one disease, that is low glucose. कुछ भी हो जाए, low glucose, treatment glucose, and they will give glucose. कोई मर भी गया तो भी glucose दे दो. And the magical thing, when they give you glucose, you become normal. It's not normal because of glucose. When you lie down, your posture become what? Supine. And once the posture becomes supine, this will improve our supply. So that is how the problem is solved. Are you clear? So that is how we are able to solve the problem. Is it clear? So this is the mechanism for solving our problem. So is it clear? So therefore, yes, when you lie down, the blood flow will correct. So that's why fainting एक तरह से क्या है? Fainting is a method of correction of the rhythm. Now, muscle pump. So muscle pump or calf muscle like soleus, they contract and they push blood into the heart. So what they do? They will push the blood where? Into the heart. Example, walking, exercise, etc. Okay. Now, venous valves. What are they doing? They prevent backflow of the blood. So, what they are doing? They are basically for which purpose? Preventing the backflow. Which valves? Venous valves are helping in prevention of our backflow. Are you clear? Of the backflow. Okay, venous valves. Then inspiration. What is there in inspiration? A negative ITP is there which pull blood into the heart and increases the venous return. Plus, sympathetic nerve causes venoconstriction. As the veins are constricted, the blood from them will shift to the heart, increase the venous return. And finally, deep fascia. It is very thick and tight. That's why athletes sometimes wear stockings in the legs. Why? Basically, it keep the muscles and the veins compressed, and that help in increasing venous return. Now, we discuss different types of blood vessel. First is Windkessel vessel. What they are? They are large elastic arteries like the aorta. So, what is aorta? Is Windkessel vessel. They stretch in systole, recoil in diastole, and that compress the blood and push it forward. This is your Windkessel effect. So, what is it? Windkessel effect. Are you clear? This compresses the blood to produce diastolic pressure 80. Yeah, thank you very much. Thank you, Dr. NEET 002. Okay, I'm here only for one motto, that is to help you, because I know there are so many sources available nowadays. Okay, सबके पास रैपिड रिवीजन है, सबके पास क्या है वो आपका जो भी क्विक रिकॉल है या जो भी PYQ सेशन है, चैंटिंग है, multiple. Okay, is now up to you people to use it for your growth in the case. Okay. Next is what they can do. They can stretch and store blood. So what they can do? They can stretch and store. Yes. Okay. Case. Okay. Chalo. Now what do they do? So first, capacitance vessel, they are veins. Veins have very high compliance. They stretch and they store the blood. So remember, veins are having high stretching power. Compliance means stretch. So they store the blood up to 50 to 60% blood. So that's why if there's the blood loss, veins can give blood from their storage to the heart and compensate the loss of blood. And that's why they can maintain the BP. So that's why BP doesn't fall. Like you donate the blood, so your BP fall, no na, वरना तो क्या होता है BP दी ऐसे दे, you give that blood and your BP fall, you are unconscious. And they say, oh, he's in shock, give the blood back. They give you 2 units and say, sorry, take again. They again take, again you become unconscious. So no, you don't lose consciousness, you don't go in shock on small amounts of blood loss. Reason, you can compensate. Up to how much if you want to write? So that's why maintain BP more than 90/60 mmHg till 30% blood loss. So how much loss? 30%. If the loss is more than 30%, then the BP will be less than 30%. This is called as compensated shock. That will be, yes, our uncompensated or decompensated shock. Are you clear? So what are the value is? Yes, 30%. So if your, again need, I tell you, we don't know what is sufficient. Okay, anything can be sufficient, anything can be insufficient. Okay, if the exam is tough, then even if you read entire Genome, you might not be able to solve the question. And if paper is good, you will get question almost all. In INI-CT, almost all the questions were covered from the notes, and 70%, 7 question out of 10 were from this PDF. So that's why, yeah, it could be both. It could be possible you can get all the questions from here, or maybe you not be able to get any question. So I'll tell you, it's going to be beneficial. That's my experience. But there's no guarantee. Okay, गारंटी आपको आपके एक्स की नहीं हुई. डू यू हैव एनी गारंटी? नो ना. क्यों? पता नहीं क्या हो कल को. वी डोंट नो. एनीथिंग इज पॉसिबल. सो बी रियलिस्टिक. ओके, ठीक है. कल किसने देखा है? ठीक है, अभी तो कल आया नहीं, जब आएगा तब देखेंगे. बट आई कैन अश्योर यू इट इज मोर देन सफिशिएंट फॉर योर प्रिपरेशन राइट नाउ. ओके, अगर आप मुझे पूछोगे एग्जाम से 1 साल पहले, तो मैं बोलूंगा या इट्स नॉट सफिशिएंट. ओके, सो आई एम गिविंग यू motivation. The biggest motivation is, if you don't want to beg other people, you don't want to be dependent on other people, you want to be independent, You have to work hard, okay? Otherwise you are always at the mercy of other people. Clear? वो आपको जॉब देंगे, वो आपको पैसा देंगे, वो इज्जत देंगे, but if you study, become successful, you can do what you want. And the biggest thing in the world for me is freedom, financial freedom, then freedom to do anything, go anywhere, and I will never ever give my freedom for anything. And that's why I work hard. Hard work give me reputation, give me money, give me, like all my recognition, and that enable me to do what I want. I can sleep when I want, I can work, I can read, I can go anywhere, I can eat, go and do anything. That is what the power of your hard work is. Independence, okay? It is not pleasure, enjoy. It is your, yes, independence in the life. ठीक है ना? चलो. Next is exchange vessels. What are exchange vessels? They are capillaries. Capillaries, yes. Hello, Dr. Pachu Fawaz. Okay. Yeah. So what is the story? It is permeable and they have simple squamous endothelial cells. So simple squamous endothelial cell. They contain minimum blood, very low pressure, very low resistance. Why? Because if they have high pressure, high volume, they can leak and cause edema. That's why capillary always contain less, because they are very permeable and can leak. Remember hemorrhage petachy occur when capillary rupture, which we discussed in forensic, remember? Yes, asphyxia, there is what? Petachia formation, cyanosis, congestion. So next is slow speed. They have very slow speed. Why? So that exchange can occur. If the speed is fast, then how will exchange occur? Like example, you are sitting in some marriage and the waiter is the capillary. He is giving you all the samosa, pakoda, etc. If the waiter is showing you attitude, what happens? He comes and go very fast in front of you. So you are thinking to pick the samosa, your hand goes and the waiter goes, shh. You say, Abhay, come here, leave the plate here. So that is what we do. So that's why capillary should be slow so that they do good exchange. And their flow is silent and laminar. So where is flow, silent and laminar? It is in the capillary. Also the capillary have very big area so that they can do very good exchange again. And there is what? Highest area and minimum speed in the capillary. What are the reason it has the high area? Because it's not one but billions of capillaries which are arranged in parallel. I can just make a simple diagram, see, like this. So ये क्या आपकी capillaries. Okay, so this is the capillaries. Okay. Next question. Now comes the question, resistance vessel. Resistance vessel. What the story about resistance vessels is? So resistance vessels are basically what? They are muscular arteries and the arterioles. So they are which arteries? Muscular arteries and the arterioles. Okay, they have smooth muscle. They have smooth muscles. Okay, and they can contract and relax. They can contract and relax. They can change the diameter and they will control our blood flow. So what they can control? They can control our blood flow. So they can control the blood flow in this case. Are you clear? So that's why they are for regulation of flow. Okay, and remember aorta is the one which has the highest speed, aorta and arteries. But if they ask max speed, aorta is the max. Aorta is maximum speed. MCQ. Okay, next question. So what are the arterioles doing? They control the blood flow. Yeah, Reynolds number more than 3000 is the hallmark for finding out turbulent flow. More than 3. Okay, yeah, main thing is I'm telling you, okay, you will get everything only after you do well in the exam. Clear? Else your entire thing is stopped. You are not able to move forward in your life if you are not able to get the exam done, क्योंकि सब कुछ अटका हुआ है, आपका अगला स्टेप, आपकी अगली चीज, सब कुछ है, आपकी पूरी लाइफ फंसी हुई है, और इसीलिए फंसना किसी को पसंद नहीं है, ठीक है। सो टू क्लियर द एग्जाम यू गेट फ्रीडम, you get everything. Imagine you'll have lots of money, you will have like foreign trips, you can buy anything, buy iPhone, buy your cars, your houses, you can make your parents very happy, you can give them something. Yeah, okay, chalo. Now next question, arterioles are the main resistance vessels. Reason, they have maximum amount of smooth muscle and they have a rich sympathetic supply. So we supply rich sympathetic supply. Alpha 1 causes vasoconstriction and beta 2 causes vasodilation. So it causes the vasodilation, whereas alpha 1 is everywhere. So what is the alpha 1? It is present everywhere. Okay, so alpha 1 is present everywhere including the skin. So this mainly where? Everywhere including the skin, GIT, kidney, muscle. So it causes constriction, whereas beta 2 is selective site like muscle, sweat gland, uterus. It causes vasodilation, increase the flow. Now remember, arterioles offer resistance at what level? Not at heart level. Aorta is at heart level. Arterioles are far away from the heart, mainly at the level of tissues of the body. That's why they are the site of peripheral resistance. That is not near the heart, away from heart. Periphery means away from heart. That is why they are called as peripheral resistance, PR. Now, if there is a vasoconstriction, so what vasoconstriction do? So vasoconstriction will increase PR, and if there is an increase in PR, the load on the ventricle will increase. So load on the ventricle will increase and they will contract more and more and more. Clear? क्या बात है सौरभ, very good. Okay, if you are watching from any place, please watch the patient's vitals also. Keep an eye on the monitor also. Okay, पता लगे आप यहाँ पढ़ रहे हो वहां कोई और फेल हो गया, ठीक है। चलो, so it is called as afterload. So what is afterload? It is resistance which require ventricle to pump with high force. So this is called as what? After. So what is it called as? It is called as the afterload. So afterload is after the contraction. It's called as what? Afterload. Now comes the question, okay, blood flow regulation. So how much blood flow any organ can get? It is given as pressure divided by resistance. So the formula is, it is our pressure by resistance. So the formula, pressure by resistance. Okay, now remember, organs can control their own blood flow by changing their resistance. What is it called as? Auto regulation. What is the term used? Auto regulation. Auto means own. So they can control their own blood flow by changing the resistance. Like example, when we exercise, our muscles need more blood. So that is why when you are exercising, the BP increases. So there is an increased blood pressure, and there is also a vasodilation. So pressure increases and resistance fall. So there is a fall in the resistance which give more blood. Now how does the resistance fall? When you are exercising, your muscles accumulate lactic acid, carbon dioxide, hypoxia, K+, H+, adenosine. They all are seen in tissue right shift also. Remember right shift? Increased temperature. So temperature, acidosis, carbon dioxide, lactic acid, hypoxia, they all cause vasodilation. So when I am writing, where will vasodilation occur? In my hand muscle. So my hand get more blood. If I am walking, my leg get more blood. If I am eating, my GIT get more blood. So any organ which is active metabolically will make the metabolites, and metabolite cause the dilation that correct the flow. This is called as auto regulation. So that is why organ change their own blood flow when they need it. This is auto regulation. Best is brain, mainly by carbon dioxide, and heart by adenosine. So who's the best in the heart? Adenosine is best in the heart, and carbon dioxide is the main in the brain. Okay, main in the brain. Okay. Now what is the formula of resistance? It is given as 8 eta. This eta is the symbol of viscosity, L pi R4. So what this symbol is, it's viscosity, how thick the blood is. If the blood has more RBC, more protein, viscosity increase. If viscosity increase, resistance will be more. Okay. Then length, longer the vessel, more the resistance. That's why long vessels, long circulation has more resistance. Example, systemic circulation is longer, so has more resistance. I'll write here. Systemic vessels are longer, that is why have high resistance. So they have high resistance. So they are longer and they have a high resistance. Okay. Okay. Now let's continue. Blood pressure. So first question, blood pressure BP. So BP is basically cardiac output into peripheral resistance. So cardiac output into PR. PR is peripheral resistance. Now first is our BP. As BP is our, so remember, whenever there is asked, remember, is 120 and it is due to ventricular contraction and depend on cardiac output. That's why in shock, there's a decreased cardiac output and decreased BP. Okay. Don't worry, you can do it. Okay. Don't worry. Okay. All in one, just give your best. Okay. Don't think about the past, what you used to do. Think about the future, that you have to do it. Okay. Thoughts are the ones which can make you study or not study. Like I get a thought, why am I working hard? Already I have all the last session physiology, they can watch it now. But problem is, if I don't get this urge to teach now, the person who has to watch, usko bhi to urge nahi aayegi. Are you clear? Even when your bladder is full, you get the urge to urinate. Same way we need an urge to study, work, because our brain is very, like difficult to manage doing the activity. Lazy. It just want to relax and enjoy. So that is why you need to force it. So me taking class will motivate people to come and sit. That's the purpose of live class is. Why I don't like apps or recorded lecture? The reason is the motivation to watch it is very less. Okay, you prefer to watch Netflix, Panchayat or jo bhi Game of Thrones, House of Dragon, but the motivation to study is less because study is boring. Clear? No one want to eat Ghia, Torai, Loki. They want to eat pizza. Same funda is here. Okay, you have to give your best, attend the class, study with me, and you will learn. And I'm trying my level best to be very, funny also. Now, DBP. So DBP is 80 and it is due to recoil of aorta in the diastole and it depends on peripheral resistance. So if there is a vasodilation, BP decrease. Example, vasodilation decrease the BP. So example, anaphylactic shock. So example is anaphylactic shock, and if there's a decreased cardiac output like hypovolemic shock, cardiac shock, again the BP will decrease. So how can you decrease the BP? One is decrease the cardiac output like in shock, or vasodilation can decrease the BP. Okay. Next question, pulse pressure is the difference between systolic and diastolic. It indicates the blood flow that organ is getting. So the blood flow is our funda. Okay. Now remember, it also indicate arterial compliance. So what it indicate? It indicate our arterial compliance. Let me give an example. Okay. First is, as the blood flow is there, we get the flow in this case. Now understand, the vessel stretch, recoil, stretch, recoil. As the vessel stretch or recoil, we get the blood flow. Okay. Now if there is a artery not able to stretch, it's not having good compliance, it's stiff. What happens? It cannot stretch properly, it cannot recoil properly. That is going to be a problem, and that's why you get a poor pulse pressure. So pulse pressure indicate compliance. ये क्वेश्चन आपका आ सकता है कि ये एम्स का रिपीट क्वेश्चन है, PYQ है कि pulse pressure indicate which of the following answer is arterial compliance. Okay. Now mean blood pressure or MBP, it is 95 to 100. So what is the pulse pressure MBP? 95 to 100, and it is given by two formulas. Both are same. One is 2/3 DBP plus 1/3 SBP. So how much? 2/3 of DBP plus 1/3 of SBP. And the MBP other formula is DBP plus 1/3 of pulse pressure. Are you clear? So this is the formula for calculation. Thank you very much, Dr. All-in-One. Best of luck to you. Now, CVS regulatory centers are in medulla. Just like respiratory center, they were in medulla pons, they are in medulla. One is VMC, vasomotor center. It increase everything. So it increase the sympathetic, so increase heart rate, BP, all. Second, they are in rostroventrolateral medulla. So which part of medulla? Rostral, ventral and lateral part. Okay. The other center is CVC. नाम से इसका दिख रहा है आपको cardiovagal. And what vagus do? Vagus is basically coming from two vagal nuclei in this case, NTS and NA. Nucleus tractus solitarius and nucleus ambiguous, that is NA. It increase parasympathetic by vagus now. And what vagus do? Via M2 receptor, decrease heart rate, decrease cardiac output, decrease BP, decrease conduction. It cause AV, block and even shock. Which way? Vasovagal shock. So it shut down the heart, causing vasovagal. Now baroreceptors, they basically control the BP. How? They are stretch receptors in our arteries. So they are checking the stretching. If there is an increase in the BP, mainly MBP, so if there is an increased BP, there would be increased stretch and increase baroreceptor activity. So there would be increase in the stretch and increase in the baroreceptor. Kya baat hai, okay. So my best wishes to you, okay, nursing students, medical student. At the end, content remain the same. Only thing is the level changes, okay. Like example, in NEET PG AIMS is competitive, so the question become trickier, more difficult, and other exam they might be simpler. So that's the case, okay. Otherwise, disease remain the same, baroreceptor remain the same. Chalo. Next question is, what are they sensing and regulating? So they regulate MBP in the range of 60 to 180. Now remember, if they are activated, they decrease the BP. Why? Because baroreceptor are stimulated by increased BP. So negative feedback means they should decrease the BP. So baroreceptor always decrease BP and heart rate. So when BP increase, baroreceptor become active, they inhibit the VMC. As they inhibit the BP, they will decrease the BP. It should be BP, not BR. And they will decrease the BP. So they decrease the BP and heart rate and bring it back to the normal. Okay. So that's the case. So this is the case. So remember, VMC increase sympathetic and that increase our BP. So try to increase the BP. But as the BP increase, baroreceptors are stimulated and the baroreceptors are going to go and inhibit our VMC. So they will inhibit the VMC. As they inhibit the VMC, it will, make the BP decrease to normal. So kya hoga? So inhibit, and that will, I'll write with blue, and decrease BP to normal by baroreceptors. So this is the summary. Are you clear? So baroreceptor will decrease the BP back to the normal. So that is what baro are trying to do. So who want to increase the BP? VMC. Who want to decrease the BP? It is our baroreceptor. And there's a fight going on between these two people. So VMC want to increase the BP, baro want to decrease the BP. So that is a fight going on. Now comes the question. If we destroy baroreceptors, the BP will increase. Why? Because now the VMC will be acting uncontrolled, okay, and that causes neurogenic hypertension. And if you destroy the sympathetic nerve, BP will fall. That is called neurogenic shock. Okay. Location. So location is same as peripheral chemoreceptor, that is aortic sinus in arc of aorta, and carotid sinus is bifurcation of common carotid artery, that is aorta and carotid. You can write bracket aorta and carotid artery. Okay. Next question. CVS reflexes. So what are the serious reflexes? First is our Bain bridge reflex. Okay, what is the story about the Bain bridge reflex? First, it's a compensatory reflex. Okay, so it is compensatory reflex. Okay, and what does, when you give a IV fluids, it causes a increase in the heart rate. Okay, and what is the result of increase in the heart rate? It causes, yes, because of the increased sympathetic. So the reason, due to increased sympathetic. So are you clear? So clear? So that is our main funda or our main story. So are you clear? Next question, right? Basalt Yarish reflex. Yeah, basalt Yarish reflex. Okay. What is the story about the basalt Yarish reflex is? So first and the foremost thing about the basalt Yarish reflex, what is that? Let me explain. So the funda about the basalt and Yarish reflex is, what happens when you give irritants, IV irritant, like example, you give capsaicin, veratridine, serotonin, they trigger the ventricular chemoreceptors, and the ventricular chemoreceptors, what are they going to do? So they are going to cause activation of vagus, so via vagus. And what does vagus do? So decrease, so via vagus they will cause decrease BP, decrease heart rate, everything will be decreased. Are you clear? Clear? So that will be the case. Are you clear? So are you clear? So that is our funda we will see. Okay. So decrease. Next question. In the lung, similar reflex is there. Irritants in the lung, pulmonary edema. This is called as the J reflex. What is it called as? It is called as the J reflex. So J reflex is also same. Decrease BP, decrease heart rate. So this apnea, bradycardia, hypotension is via vagus, and this is seen in J reflex also, Jarish reflex also. And finally, there is a Mary's law. What is Mary's law? Is the reverse relation between BP and our heart rate. So what is it called as? Mary's law. So first, in shock, it say BP is less, but heart rate increase because of increased sympathetic, that causes reflex tachycardia, and that is what is Mary's law. Whereas in Cushing's, if there's an increased ICT because of, let's say, there's a head injury or maybe there is some kind of stroke, if there is an increased intracranial tension, it causes increased BP. Okay, so blood pressure increase because of increased sympathetic from the VMC. As BP increase, heart rate will be decreased by baroreceptor through vagus. This is called as reflex bradycardia. So remember, whenever BP is increased, the heart rate will be decreased by baroreceptors, and if there is a decreased BP, heart rate will be increased. That is our Mary's law. So what law? Mary's law. So now comes our urinary system. Okay, now kidney. In kidney, what is the functional unit? It is nephron. So what is that? It is nephron. And one more thing is, if they give you graph, this is cystometrogram. So cystometrogram अगर आया, ये ऑलरेडी आ चुका है. इसका ग्राफ ऐसे होता है, इनिशियल वन फेज, देन एंड दिस इज 1A, 1B, phase 2. Remember, 1B is called as it's a plateau phase. It is due to, I'll write here. So 1B is due to plasticity. Bladder has a capability of stretching, plasticity, and Laplace law. What is Laplace law? Laplace law say P pressure is 2 tension by R radius. So what happens? If the radius of the bladder increase, the pressure will remain low despite high filling and wall tension. This is Laplace law. So they will ask you, and what is 2? 2 is when there is a high volume, contraction occur which cause voiding. So in phase 2, contractions occur. phase 1b, the bladder stretches and able to keep pressure low. That is called as plasticity. Okay. Now, the two parts of the kidney are cortex and medulla. Now, cortex is containing almost every possible part, but what is there in medulla? Loop of Henle and MCD. This is called as MCD, medullary collecting duct. It gives the urine out. So this is medullary collecting duct, MCD. So what is MCD? Medullary collecting duct, MCD. Now remember, what is the blood supply? So afferent arteriole give the glomerulus. This is glomerular capillary, GC. Then it give a efferent arteriole. This is the efferent arteriole. And then we have the PC. This is PC. This is also PC. PC is peritubular capillary. So what is this network is? PC is peritubular capillary, and the branches in medulla, PC branches, is called as vasa recta. So capillary network of medulla is called as vasa recta. So I'll remove this from here and I will just put it here. So what is PC? Peritubular capillary. I'll write here PC is peritubular capillary. Okay, so these are the PCs. Okay, so these are our PCs. So clear? Chalo. So let's continue. I'm using a colored pen only, भाई. ठीक है? Blast. I'm already using a colored pen. ठीक है? Sometime I use red. देखो ना कितना कलरफुल लिख रहा हूँ. देखते रहो. अब इससे और क्या कलर करूँगा? Okay. So red, blue. Clear? चलो. Okay. Next question that we see is, right? Glomerular capillary, they filter the plasma, and once they filter the plasma, mainly on what basis? Size basis, also charge and charge. The substances enter the tubule. So after filtration, where do the substance enter? The tubule, like this. Now this is the tubule. This is our glomerular capillary. This is afferent. This is efferent. This is GC. And this is peritubular capillary, PC. So what happens is, after filtration, everything is in the tubules. Now good things which you want them back to the blood. So good things, they are brought back to the blood. So they enter the blood back. This is called as R. R for reabsorption. So good solutes go back to our blood, like glucose, water, amino acid. This is called as reabsorption, R. Whereas unwanted dirty things, you will secrete them. This is called as S. S for secretion. So secretion is putting things from our blood to the urine, like drugs, toxin, metabolite, urea, uric acid. This is removed by secretion. So the three steps of urine formation. First is okay, our filtration, which is glomerulus function. So glomerule will do this, and reabsorption is a tubular function. Secretion is also a tubular function. So these are our which functions? Tubular function. Now comes the question, glomerular filtration membrane has how many layers? It has 3 different layers. So what are the 3 layers? First is endothelial cells of glomerular capillary. Okay. Now comes the question, what is the cells have? They have opening. क्या कहते हैं उन्हें? Fenestrations. What are the opening between endothelial cells are? They are called as fenestrations. Okay. Then come our basement membrane. Basement membrane contain negatively charged sialoproteins and heparan sulfate. So which sulfate? Heparan sulfate. So what do you have? They have the negatively charged sialoproteins and heparan sulfate. Okay. What they do? Negative repel. So that's why the negatively charged plasma protein like albumin, they get filtered out. So they get repelled. So they don't get filtered because of negative charge. And finally, epithelial cells of Bowman capsule, they are also called as podocytes. What they are called as podocytes. And they have foot-like process. Can you see this? So this is the foot-like process. This is foot process, foot. Okay. So this is the foot process. And they have openings called as slits, 10 to 20 nanometer. So the three layers: endothelial cell, fenestration, negative charge in basement membrane, and the slits of the podocyte. The net filtration pore size of the membrane is 4 to 8. Very important point. So net filtration pore size is 4 to 8. So what is the meaning? Anything which is less than 4 are freely filtered. So what they are? They are freely filtered. Example, inulin, glucose, sodium, they are what? They are freely filtered. So they are which substances? Freely filtered substances. Are you clear? Then if something is bigger than 8, it is not filtered, like RBC, WBC, platelets. So they are filtered, not filtered. So they are not filtered. Okay, so they are filtered, not filtered. They are not filtered and they will not come in urine. Also globulins. Now myoglobin, is myoglobin filtered? No, it is not filtered. Why? As it is bound to plasma protein, and same way hemoglobin is bound to haptoglobin. It's not globulin, it's haptoglobin. So that is why it is again not filtered. Clear? So haptoglobin. Next, if something is between 4 to 8 nanometer, it will depend on charge. Example, albumin size is roughly 7 nanometer. So it is filterable by size but not filtered due to the negative charge. Are you clear? So what is the reason it is not filtered? The answer is the negative charge prevent the filtration. So it's the negative charge which is responsible for preventing the filtration. Are you clear? It is inulin. Where's insulin? I think by mistake. It's inulin, not insulin. Okay, creating happiness. It is inulin which is freely filtered, not insulin. Insulin is not filtered. Okay. Okay. So if there's a loss of charge disease, nephrotic syndrome, there's a albuminuria. Example, minimal change disease. For the example, yes. Good evening. Good evening. Minimal change disease, MCD. Again, I discussed that in our pediatrics class also. Okay. Okay. If it is insulin, please correct it. By chance, by mistake, I might have written it. It happens sometime. You make mistakes, so please correct it. It should be inulin. Okay. PCT. Now PCT is an area which is having highest blood supply, highest oxygen, highest ATP. Why? Because maximum secretion and reabsorption occur here. So where is the highest amount of secretion and reabsorption? It is in the PCT area. So which area? PCT. Now remember, all substances are maximally reabsorbed in what? In the PCT. What is the only exception? It is magnesium. So where is magnesium reabsorbed? It is in the ascending loop of Henle. Yeah, type 2 is in the which area? Type 2. Type 2 is PCT. Type 1 is distal tubule. Okay. Type 2 is, yes, PCT. Type 1 is distal tubule. Okay. Next question. Okay. Where is everything secreted? Answer is PCT. Exceptions yaad kar lo, very important. Magnesium is in ascending loop. Potassium secretion P cell. Urea secretion thin loop. So these are the exceptions. Otherwise, everything else is maximum in the PCT. So what is the everything maximum? It is in the PCT. We see highest possible secretion or maximum values. So is it clear to all of you? So everything is maximum in which area? It is in our PCT, PCT, PCT and PCT. Everything is max there. So clear now? ठीक है, चल लेट्स कंटिन्यू। Okay, so just checking the schedule for classes. Okay, so let's continue. Okay. Now remember, highest acid secretion occur in which area? So remember, highest acid secretion occur in our PCT, and it therefore uses maximum buffers to maintain pH by neutralizing H plus. So it neutralize the H plus. So neutralize the H plus. Okay. Next is, what are the main buffer? Main buffer is which one? Is our bicarbonate. So it is our bicarbonate, and it needs the enzyme carbonic anhydrase. The minor buffers are ammonia and phosphate. And remember, ammonia is a inducible buffer. Ammonia is inducible. Yeah. If they ask you where does bicarbonate blocking drugs act, like this carbonic anhydrase inhibitor, they act in the PCT. So ammonia is inducible buffer, as it is made by tubules, made by kidney. That is why you can make it as much as you want. So which is the inducible buffer? Inducible buffer is our ammonia. Okay. Now loop of Henle has a very high osmolarity. How much? More than, plasma, around 1200. So it is 4 times more than plasma. So the word we are using for 4 times more, hypertonic. So where is the highest osmolarity? It is in plasma. 4 times more is in medulla. That is called as hypertonic. Now in the medulla, because of high osmolarity, it can pull the water from the urine and make a concentrated hypertonic urine as high as 1200 in descending loop and collecting duct. That is why it is the area which concentrate the urine. But remember, CD need ADH also. Now longer the loop, more it has the power to concentrate the urine. So सिंपल सी बात है, जितना लंबा होगा उतना अंदर तक घुसेगा, और अंदर तक जाएगा तो उतना ही पानी निकाल पाएगा, अब्सॉर्ब कराएगा. तो दैट्स पे याद करना, बड़ा है तो बेहतर है, लंबा है तो डीप है. दैट्स व्हाई इट इज लॉन्गर द लूप, more the concentration power. So what is the power? More is the urine concentration power. Done. Next question. Okay, so it is having more and more power to concentrate. Clear? Now remember, descending, drink, so it's water permeable, and ascending is eat the salt, it is solute permeable. So descending drink the water and make what? Urine. It make hypertonic. ये क्वेश्चन कई बार आया है. So who make hypertonic? It is the descending. Ascending make hypotonic urine, which goes to DCT and CD. So DCT, and in CD ADH decide the ADH decide osmolarity, which I'll discuss very soon. So CD ADH is the boss. Okay, now next question. Okay, yes, it is our counter current system. Counter current system help in increasing urine concentration. So what is the story? It is multiplier, which is ascending loop, and exchanger is vasa recta. So multiplier add salts. एक वर्ड में याद कर लो, it add salts to medulla and increase the osmolarity, whereas exchanger remove water. So exchanger is removing the water. So exchanger is vasa recta and it remove water. So one line summary. Who add the salt? So add salt is by the, yes, which structure? Add the salt is by, yes, multiplier, and water remove by vasa recta. So vasa recta is the case. Chalo. Next question. What is the story about our, yes, main transport and ascending loop? So thick ascending contain NKCC. What is NKCC? Sodium potassium chloride co-transport. So sodium potassium chloride co-transport, and it is blocked by loop diuretics. 100% exam question. And it is defective in Bartter syndrome. So Bartter syndrome, there's a defect in the ascending loop of Henle, and there's a loss of almost every possible salt in the urine. So loss of solute is your, yes, Bartter syndrome. Here I told you already, the urine in the collecting tubule or duct is hypotonic initially. It is hypotonic. Now ADH will absorb the water and make urine concentrated by ADH. So that's why ADH will cause water absorption and make urine concentrated hypertonic. Thanks to what? Thanks to our water pulled by medulla. This is medulla. 1200. Okay. Chalo. Next is this early DCT. So early DCT, first question is having NCC. What is NCC? Sodium chloride co-transport. It is blocked by thiazides and defective in Gitelman syndrome. So what syndrome? Gitelman syndrome. So defective in Gitelman syndrome. Now comes the question, in CD, what are the types of cells? So there are two type of cells in the CD which are also present in the DCT. First is I cell, which are intercalated cells. For which secretion? For acid secretion. So what secretion? For the acid secretion. And they are mostly making what urine? Acidic urine. So what they are making? Acidic urine. And what is the pH? The minimum pH is 4.5, which is called as the limiting pH. Okay. So what is causing the acid secretion? I क्या करता है? Acid करता है. Acid, id. So it's caused acid. Now P cell, very special. They are principal cell. Principal क्या करता है? वो क्या करता है? आपका सोडियम को reabsorb करेगा and kick out the potassium. So it bring the sodium to the blood and kick potassium out. That's why it causes decreased blood potassium, hypokalemia, and causes our hypernatremia. So hypokalemia and hypernatremia. And what are the channel? Channel they use is ENaC. What is ENaC? Is epithelial sodium channel. And who block the ENaC? It is blocked by amiloride. Amiloride is therefore used in two diseases: excessive ENaC activity in Liddle syndrome and lithium induced diabetes insipidus called as this. तो उसका निमोनिक याद करो, लिली. एक छोटी बच्ची है लिली. लिली. What is लिली? Lithium induced and Liddle. So लिली को आपने क्या बोला? आओ मिलो और लोराइड, अमीलोराइड. सो किस में यूज करते हैं अमीलोराइड? अमीलोराइड इज यूज इन लिडल एंड लिथियम इंड्यूस्ड डीआई. तो क्या बोला आपने? लिली को आओ मिलो लोराइड. एंड हु स्टिमुलेट आवर P cells? Aldosterone. So aldosterone increases sodium, decreases potassium, and also cause acid secretion. So it causes alkalosis. So what is the picture of cones? It is hypernatremia, hypokalemia, and metabolic alkalosis. Drug of choice is spironolactone, which is aldosterone antagonist. The reverse is Addison disease. So in Addison disease, there is low aldosterone. So low aldosterone is Addison disease. How to remember? The main hallmark is, let's say Addison, Ajay Devgan. So Ajay Devgan add करता है ना किसकी? भोलो ज़बा केसरी. So Addison. So Addison में याद कर लो क्या होता है? Earlier इसको थी विमल की क्रेविंग. किसकी थी क्रेविंग? विमल. So earlier he had Vimal. Now he is not having Vimal but salt craving. So just to show you craving, I use this photo. So this person has intense craving. So he keeps salt packets and he keep on gulping the salt as if he's bolo zaba kesari, now bolo zaba namkeen. So namkeen zaba karega, ठीक है? So that is craving of the salt. MCQ. ये question आ चुका है exam में. They ask what disease the person is having intense salt craving. The answer is Addison's disease. So it is our Addison's disease. Okay. Now comes our second important question. What is the question in this case? So let's see that. Okay. It is treatment. So what the treatment is? Hydrocortisone. So treatment is our hydrocortisone, which is the drug of choice or the treatment in this particular case. So are you clear? Chalo. Next question. The question that we see is our yes, right on? The CD. So CD is water and urea permeable with ADH receptor V2. So when the ADH is there through urea transporter 3, it make the urea from urine enter the medulla and increase medulla osmolarity, and that's why it help in counter current system. So urea is very beneficial for what system? For our counter current system. So what is helping the counter current system? Yes, it is basically by our ADH. Also, is it going to increase what? It is going to increase what? It is going to increase our water absorption through aquaporin 2. तो याद कर लो कौन सा वाला है ये? Aquaporin 2. और रिसेप्टर कौन सा है इसका? V2 receptor. So I hope is clear now. So it is our V2 receptor is this case. So V2 receptor. So क्या है आपका receptor? V2 is the receptor. So are you clear now? So V2 receptor. And it causes water absorption. And if you absorb the water, more water absorption, more like saving of the water, and the urine will become hypertonic and concentrated. So what the urine become? Hypertonic and our concentrated. So that is the funda. Are you clear? So what is doing it? ADH is doing this particular change. So making the urine hypertonic and concentrated. So are you clear now? Now, if ADH is not there or not working, let's say the defect in ADH. So now CD is less water permeable, less absorption. And if there is less water absorption, urine become hypotonic because you're not absorbing the water, and there is going to be high urine volume, which cause increase urine output, called as what? It is called as polyuria. Also the thirst increase, polydipsia. So polyuria, polydipsia. So polyuria, polydipsia. Now how much blood kidney gets is called as the renal blood flow. Is called as what? Renal blood flow. How much is the value? 1200 ml per minute is the value of renal blood flow. Out of that, how much is our liquid plasma? It is our 625. So remember, 55 to 60% of blood is plasma. It is plasma. Okay. So that is the case. Now out of 625, how much gets filtered? It is 125 ml which gets filtered, and this is GFR, and in volume wise it is 180 liter. So 180 liter a day is the value. So what is the value? 180 liter a day. Second, what is the clearance? Clearance is basically UV by P. So what is clearance is? UV by P. So U is urine concentration, V is volume, all right. And V is volume of urine per minute. Are you clear? So this is the funda. U for urine concentration, P for plasma, and V is volume of urine formed per minute. Are you clear? So that is the funda. Okay. Now next question, if only filtration occur and no secretion, no reabsorption, then the clearance become equal to GFR. Example is inulin. So inulin clearance is GFR 125 ml per minute. That's why it is used for GFR estimation. If you start secretion also, the clearance will increase and now it will be more than GFR. Why? Because you are filtering plus secreting. So if you are filtering and secreting, you have obviously more value than the filtration. What is the rate of filtration? So rate of filtration is GFR, na? So your clearance is equal to filtration rate, okay? But if you are having secretion, it will be more than GFR, okay? More than GFR. Example, creatinine. So creatinine has a value 130, which is obviously more than GFR. So it is more than GFR 125. So it is getting secreted, but it's very little secreted. That's why it's very close to GFR. That's why it is used for GFR estimation. Now remember, most accurate, if they ask you, answer is inulin. But what is more commonly used? Creatinine. Why creatinine? It is endogenous, is already there in the body. Already in body, whereas inulin has to be injected. Yeah, has to be injected. So what is already present? Yeah, creatinine. So it is easy. So easy method, if they ask you, it is our creatinine. Difficult is inulin because you need to inject. Now if you do full secretion, there will be full clearance, and full clearance means you clear all the plasma. What is plasma coming called as RPF? So now your clearance become equal to not GFR but RPF. So what is RPF? Amount of plasma coming. Have you cleared all the plasma? Yes. Example is PAH. So what is pH? Para amino hippuric acid. It is used for GFR estimation. So which estimation? GFR estimation. And finally, if reabsorption occur, the clearance will decrease. So the decreased clearance. So there's a decreased clearance less than GFR. Example is urea, because urea is reabsorbed for counter current. Its clearance is not 125 but below 125. And if you do 100% reabsorption, 0% cleared in urine, nothing is left in the urine, all goes back to the blood. So clearance will be 0. Example is our glucose or amino acid. So example is glucose or our amino acid. So glucose or amino acids is the case. Are you clear? Done? Now comes the next question. What is the other important thing that we will see, discuss or have? Remember, if high glucose concentration, then glycosuria occur. That is, glucose comes in urine. That means now the clearance is increased. So increased clearance above 0. That means if glucose is fully reabsorbed, 0 clearance, nothing is coming in urine. But if there's a very high concentration like diabetic, can it come in urine? Yes. So now the clearance is increasing. So this is the graph I am making. Please make it with me and see. Okay, this is 0, this is 125, this is 625. Okay, these are clearance value. So now have a look. Look at 3 different substances. This is equal to GFR. This is equal to GFR. It is inulin. So inulin is equal to GFR. So it's equal to GFR inulin. So I'll write here GFR. Then glucose. What is the value? It was 0 in the beginning. So glucose is 0 in the beginning. 0. But then it starts to rise. This is glucose. Clearance will rise. Same way, PAH. What is the clearance? Equal to RPF, 625 RPF. Then it will decrease because of same funda. This is pH. So this graph was asked in the recent exam, and I'm telling you it can be asked in your exam. Be very clear if it comes. So the one which is falling downward, the one which is going down is pH, one which is rising up is glucose, and the one which is flat is our inulin. Inulin or GFR is giving you a flat curve. So what curve? Flat curve in this case. Okay. So are you clear? Okay. So is it clear to all of you? Okay. Now next question, glucose is 100% reabsorbed in which area? In our PCT. So which area? In our PCT. And funda is, what does the PCT going to do? So this is very, very important thing, that this is going to cause what? Yes, this is okay. Yes, this is our amount absorbed. So kitna ho raha hai absorb? 100% in the PCT by SGLT2, which is on the apical border, and blocked by gliflozin, which I discussed already, and GLUT2 is at the basal border. So what is the GLUT2? GLUT2 is our basal border. So it is our basal border in this case. So clear? आगे चलते हैं. Yes. Now, what is the maximum amount of glucose that we can reabsorb per minute called as? It is called as our TMG. What is it? It is our TMG. What is full form? Transport maximum of glucose. Okay. Twinkle, just understand. If a graph is 625 clearance, this is clearance, na? So if the clearance is 625, it is equal to RPF. This is pH. But there's a limit to secrete the pH. If there's a very high amount, it cannot be secreted, so its clearance will decrease. Whereas inulin is neither secreted nor reabsorbed, so it remain 125. So what remain 125? Inulin. Whereas glucose initially is zero clearance, but it rises because there's a limit to reabsorption. So that's why glucose will increase, PAH will decrease, and inulin remain unchanged. So what remain unchanged? Inulin remain unchanged. Are you clear, Twinkle? Next question, what is the story about our filtered load? What is filtered load? It is the amount of substance or glucose getting filtered per minute. What is the amount we can reabsorb called as? TMG or Tmax. Now understand, if filtered load is more than TMG, that is 380, 390, 400, you can absorb 375, but the remaining glucose will be lost, and this is the reason glycose or glucose urea occur. Are you clear? So that is causing glucose or glycose urea. Okay. So there are two conditions which causes the glycose or glucose urea. One is high load. So high load causes glycose urea. Example, diabetes mellitus. So in diabetes mellitus, there is a very excessive load. So kidney fail to work. As kidney fail to work, there is a loss of the glucose, and that's why there is a glucose urea. Or there is a less reabsorption, like tubules are damaged, they are not working, that is why there is a loss of glucose. Example, Fanconi syndrome. So what syndrome? Fanconi syndrome or acute tubular necrosis. So tubules are damaged, so tubular necrosis. This again causes decrease. And what is RT is? RT is renal threshold. What is that? It is plasma concentration where glycose urea occur. It is plasma concentration above which glycose urea occur. Are you clear? This is our RT or renal threshold. Are you clear? So RT or renal threshold. Okay. Now lastly, we have the JG apparatus. JG apparatus has three type of cell. JG cell. So JG cells are macrophages. They lyse the bacteria. They cause lysis of pathogen. So how to remember? Lysis. Lysis cause lysis. So lysis cause the lysis of the bacteria? So clear? Okay. Now JG cells in afferent arteriole, what they do? They sense renal blood flow. They sense the renal blood flow and they release renin if there is poor blood flow. So it is poor blood flow. Okay. So if kidney doesn't get the blood, like in shock or low BP or hemorrhage or sympathetic or renal artery stenosis, what is going to happen? So now what is going to happen is, okay, so liver release angiotensinogen, which is inactive. Renin convert it into angiotensin 1, which is again inactive. Then ACE in the lungs create angiotensin 1 to 2, which is active. And this angiotensin 2 causes vasoconstriction, which increase the BP. Also thirst, which increase the volume. ADH aldosterone, which increase the volume and the sodium. This system is called as RAS, renin angiotensin system. So RAS, renin angiotensin system increase BP, volume, everything. Lastly, we have the macula densa cell. Macula densa cell, what are the property? First question. They are in the DCT and also ascending loop of Henle. But the location is DCT and thick ascending loop, thick ascending. Second, it is for GFR regulation, called as tubuloglomerular feedback. So they check the GFR via tubules and correct the glomerular filtration rate, GFR, called as the, yes, tubuloglomerular feedback. Now remember, first sense GFR via sodium and chloride level. So which levels? Sodium and chloride level. In which fluid? In our tubular fluid. So which fluid? In our tubular fluid. If there is any problem in the sodium and the potassium chloride, that means GFR is not normal. And if GFR is not normal, they will make it correct. So what they will do? They will make the GFR correct, and this is how they will function or they will work. Are you clear? And that is the case. Now what they do? They use intraglomerular mesangial cell, which are contractile. So if they contract, they decrease the GFR by squeezing the glomerular capillary. If they relax, they increase the GFR. So that is how you are able to control our GFR. Now finally, if you constrict the efferent arteriole, like let's see diagram. So this is efferent. So if you constrict the efferent arteriole, if you constrict it, the blood will not go forward, and as the blood accumulates, it causes the increased pressure. This is hydrostatic pressure, HP. As HP increase, it will push fluid into glomerulus and increase the GFR. So this is GFR. So GFR will increase. So that's why remember, efferent arteriole constriction by angiotensin 2 decrease the blood flow but increase the GFR, because the blood will accumulate in the glomerular capillary. And finally, efferent arteriole. What does efferent arteriole do? So basically, dopamine causes the dilation of the afferent arteriole. As afferent dilate, more blood comes, and as more blood comes, more is the hydrostatic pressure, and it causes increase in the GFR. That is why dopamine is drug of choice and increase urine output. Increase. That is why dopamine is drug of choice for shock with oligouria. Shock with oligouria is there. So that is the funda. Okay. So now we see I'm covering everything in proper detail explanation. So I'll just take a 10 minutes break. Okay. So 10 minutes break. I'll start at 9:50, 17:50, and then we will have. Okay. So let's take a break 10 minutes and then I will resume. Okay. At what time? It is, yes. So we'll resume at 7:50 p.m. Chalo. Take care. I'll come. Let's start. Chalo. I'm not watching. I was eating food actually. I didn't had my lunch today because I got late. So I ate now. I had my. So let's start. I am back. Please join in. Yeah. Today there is a match, I know, but again, we don't have time to watch matches. I have multiple other work. I have meeting with again faculty. Okay. Also, I have meeting with that NMC issue. Okay. So multiple work. Okay. I never get free. I always have some work. Okay. Let's start. In the CNS, we have the neurons and the glial cells. Remember, neurons are around 100 billion. So what is the number? 100 billion. And remember, there is no new neuron formed after birth except hippocampus and olfactory epithelium. So olfactory epithelium is the case. Okay. We'll take class till I think 8:30, 8:40. Okay. Then again I have to check my schedule. If I'm free, we'll start medicine. Otherwise, I'll take medicine tomorrow. And after finishing medicine, we'll start with surgery. Okay. So tomorrow we'll do medicine and surgery after that. Okay. Let me check my schedule. Let me first finish this. Okay. Now, next question, types of glial cells. What are the types of glial cells? First, they can form new all life. Okay. Example, gliosis. Gliosis is after injury proliferation. And what is glioma? It's a tumor. Glioma is a tumor from the glial cell. So glial cell tumor. Now, types of glial cells. What are the types of glial cell? One is microglia. Remember, microglia put bacteria in microwave and eat. तो क्या करता है ये? Phagocytosis. So microglia is for phagocytosis. What is it for? Phagocytosis. Okay. Then we have the oligodendrocytes. What they do? They make myelin. So oligomyelin, lily. तो क्या करता है ये? ली micro myelin banata hai. Okay. And in the PNS, it's the Schwann cell which make the myelin. In the brain, it's the Schwann cell, oligodendrocyte, and in the nerves, it is the Schwann cells. Then ependymal cell. Pen we used to make line. Remember what do you do with pen? Pen is used to line, make a line. So lining cells of ventricle, they cover the ventricles. Then astrocytes are the main supporting cells. Also, they help in repair, growth, also supporting cells, and they help in blood-brain barrier, which is made by tight junction. So what reinforce them? The yes, astrocytes reinforce them. Now CSF is 150 ml and the daily production is 500 ml per day or 20 ml per hour, and same is absorbed and gets absorbed. So it is getting absorbed. Second question, secretion. Secretion is, thank you Dr. Need, absorption. Secretion is choroid plexus. So what causes secretion? CC. Secretion is by choroid plexus. Okay. And A, absorption is arachnoid villi. Is absorption. Absorption is our arachnoid villi. Okay. What is the normal pressure? Normal pressure is 50 to 130 mm water, or in mercury it becomes 5 to 10. Remember, 1 mm mercury is equal to roughly which value? So 1 is equal to 13.6 mm H2O. So that is why it converts to 130. Okay. Now CSF function, it gives nutrition like oxygen, glucose, amino acid, ions. It was ion, but it looks like this. So all ions like sodium, potassium, chloride, they come from CSF, all the ions. Then also it is responsible for which function? For our etc. Okay. Waste removal. Also what removal? Waste removal. So what is the funda about waste removal? So it is removal of every waste. Then it also maintain temperature, pH, osmolarity, etc. So everything. Okay. Yeah, it's sufficient for NEET PG. Okay. Because I'm covering everything which is asked in the recent exam, all the PYQs of NEET, INI-CT I'm covering, okay. Then also it is a shock absorber. That's why when your head hit, let's say I sleep, my head hit the pillow, it can damage the brain. But why is not damaging? Because CSF act as a, yes, shock absorber. Any impact to the head, it take it, and that's why it prevent the, yes, injury to the brain. Okay, yeah. Chalo. Next question. CSF. CSF is very similar to plasma but lower concentration, except carbon dioxide, bicarb, magnesium chloride. They are lower or higher concentration. They are in higher concentrations in the CSF. Now, let's see the anatomy of the neuron. These are the dendrites where synapses are formed. This structure is called as soma or cell body. Then this is our nodes of Ranvier, which are between myelin sheath, maximum sodium channel. Then we have the myelin sheath. The gap between the myelin is our node of Ranvier. So what the gaps are? I'll just cover them. Okay. This is the nodes of Ranvier. So nodes of Ranvier are gap between myelin. Then the first area is called as our axon hillock. Okay. So what is axon hillock? Is the area between the axon and the cell body is called as axon hillock. Action potential genesis occur at the axon hillock due to minimum threshold. Okay. Next question. The AP travel along the axon, and once the AP reach the what? Synapse, it causes neurotransmitter release. So it causes a neurotransmitter release with the help of via snare proteins. MCQ. So what caused the help? Answer is snare protein. Thank you, Dr. Abhishek. Okay. Kaisa mere bhai? Okay. So I hope you all are doing good, including you, Dr. Abhishek. Okay. Now, next question. Nissl granules in cell body are actually free ribosome. What they are doing? They are basically for protein synthesis. So what are their primary purpose? So primary purpose is protein synthesis. Okay. So it is protein synthesis, and they break down when there's an injury to the neuron. So in neuronal injury, they break down. So what is the first change? So first change is always, it is what? It is a breakdown of the Nissl granule. So what is that? It is a breakdown of the Nissl granules. That is the first change we can see or we can have. Are you clear? Clear? Okay. Next is, okay. Next is RMP and AP. Remember, membrane of the excitable tissue like muscles and neurons, they are selectively permeable. Okay. At rest, they are permeable to which ions? Potassium and chloride. So they are called as diffusible ions, but not permeable to sodium, calcium, phosphate, proteins. So they are called as indiffusible ions. Clear? So that is the case. I know, Bhai Abhishek, you were there in the first batch we had. Okay. So again, we remember people who are there with us in the beginning. Okay. Next question. If there is ions which are indiffusible, they cannot move. So that is why there is an uneven distribution of the ions across membrane called as Gibbs-Donnan equilibrium or Gibbs-Donnan distribution. What happens here? Here basically what happens is the sodium, potassium, all are there, but they are not equal. Like example, potassium in ICF is not equal to potassium in ECF. So potassium in ICF, it is not equal to potassium in the ECF. Okay. Now comes the question, what is the story here? So ICF, what are the main ion? Cations are the main in the ICF. Okay. Outside we have the chloride as the main. So chloride is the main anion outside and cation main is inside. Okay. So I'll just remove this plus minus. It just confuse you. So now what the potassium do? It want to go out. So it will try to go out, and sodium, calcium want to come inside because they are more outside. Phosphate proteins are more inside, chloride is more outside. So this distribution which is not equal is called as what? Gibbs-Donan equilibrium. Now comes the question, because of the unequal concentration, sodium, calcium want to come inside and create a plus value, potassium want to go outside and that create currents. These currents are given by equilibrium potential, and the equation we use is the Nernst equation. Okay, so Nernst equation say, let's say the EP value for the potassium is given as minus 60 MV log base of 10 with potassium inside by potassium outside. It give you potassium value. Okay, so that is how you calculate the value. Okay, chalo. Now what are the EP values? So what is the funda about the EP values? Sodium is plus 60. So what are the sodium is plus 60. Cation come inside, create the positive value. So it's a cation coming inside, create a positive value. Now calcium is again a cation and again coming inside. So both create plus because they are coming inside. Whereas chloride is an anion, negative charge which is coming inside. So it creates a negative value. Potassium is a cation, but it is going where? But it is going out. As it goes out, it causes a loss of plus, hence negative. So what is the value? Sodium, calcium plus coming inside. Chloride minus anion coming inside. So negative. But potassium is going out. That's why the value is different. It gives you our negative value. Are you clear? So it gives you which value? Positive, negative. It gives a negative value. Now, RMP. What is RMP? If you take a cell and you put voltmeter, this will give you RMP. So what it gives you? RMP can be given. Now, RMP depends on what? Potassium and chloride. Why? Because membrane is not permeable to sodium at rest. That is why RMP depends on potassium and the chloride. So what it depends on? It depends on potassium as well as the chloride. So potassium and the chloride. Okay, clear? Okay, next point. So what is the ion which is causing the RMP? It is our potassium and chloride, and they both create negative EPs. So that's why RMP is always negative. So why is the RMP always negative? It is because of which phenomena? Because of a very simple phenomena, that is our membrane is permeable to the potassium and it create which value? A negative value. Okay. Now, what are the RMP of neurons? So neuron RMP is approximately minus 70 millivolts. What are the values? Minus 70 is the value. Then skeletal and cardiac muscle is minus 90. Smooth muscle, thyroid minus 50. RBC minus 12. So RBC is minus 12. Rods and cones minus 30 to 40. Cochlea hair cell is minus 40. Okay, minus 40. Now remember, if you give a stimulus and the membrane become less negative, it is called as depolarization. Let me explain it. So what is the depolarization means? It is less negative. So RMP is already negative. If you become less negative, the term we use is depolarization. But if you become more negative is called as hyperpolarization. So please don't forget, hyper is more negative. I'll write here, hyper is more negative, D is less negative, and negative is RMP. So RMP is negative. If it become more negative or less negative, this is our funda about the RMP. Are you clear? Next question. Okay. So when the membrane depolarize up to a special value called as firing level. So when the membrane reach firing level, action potential can occur. This is AP. So if depolarization occur till firing level, what we can get? We can get a AP. What is the firing level? Minus 55. So at minus 55, sodium channel open and create action potential. So what is created? Action potential is created. That is why our depolarization is what in nature? It is excitatory in nature. So who's excitatory? Depolarization. Okay. Next, right? So next we see is the depolarization and our hyperpolarization. What is the difference and the distance between them? So we'll be discussing and we'll be seeing it. What is the story and what is the funda about that? So right. So first question. If there is a depolarization at synapse, what is this depolarization at synapse called as? It is called as our which phenomena? It is our EPSP. What is EPSP? Excitatory postsynaptic potential. So what is EPSP? Excitatory postsynaptic potential. And what is hyperpolarization at the synapse due to neurotransmitter called as? It is called as IPSP. What is it called as? IPSP. Okay. Now this is the story of EPSP and IPSP. Very good. Now first question, how does neurotransmitter cause EPSP, IPSP? The neurotransmitter, when they are released at synapse, they bind the receptor. So they will bind the receptor. As they bind the receptor, they open the ion channel, and this ion channel causes the current. Like example, sodium channel, when you open, it brings the sodium and cause a depolarization or EPSP. And the result is we get glutamate is what? Causing the depolarization. Okay. And it is NMDA receptor. So what receptors? NMDA receptors is the case. So NMDA. Okay. And it is the main excitatory neurotransmitter in CNS. So who's the main excitatory in the CNS? It is glutamate. Next question. When you open calcium channel, again same thing. Calcium causes a calcium entry channel and cause depolarization. Again excitatory. Example is substance P. Substance P is the neurotransmitter for pain pathway. Example, when there is an injury, there is a release of substance P. It stimulates SG cell, which is substantia gelatinosa. And this substantia gelatinosa is the first neuron of the pain pathway. As you activate the substantia gelatinosa cell, it causes pain. And that is called as algia, algesia, dolor, which is same for pain. So how pain is produced? Answer is calcium channel opening. Now next is potassium channel opening. So when you open potassium channel, there is a potassium efflux. What is there? Potassium efflux is there, and potassium causes again negativity. So hyperpolarization or IPSP. So which SP? IPSP. Second question, morphine inhibit SG cell by what receptors? By mu opioid receptors. Okay. And that inhibit the pain. That is why morphine is a very potent analgesic agent. So is what agent? It is our analgesic agent. Now open the chloride channel. If you open chloride channel, chloride will come inside because more outside and create hyperpolarization. Example is glycine is the main inhibitor in spinal cord. In tetanus, it is lost. Remember, I told you tetanus is increased excitability of neurons because of loss of glycine. And in brain, it is GABA. That's why GABA is the main inhibitory in the brain and glycine in the spinal cord. Now let's see AP. When you give a threshold stimulus, so when you give a threshold stimulus of plus 15 millivolt, it causes action potential. But if the stimulus is less than threshold, there will be no AP. This is called as all or none law. That is, either we get 100% or 0% response. That is, either we'll get the AP or we will get no AP. This is called as all or none law. Okay. Now threshold stimulus of plus 15 millivolt. Okay. So what is the stimulus? Plus 15 millivolt. It changes the RMP from minus 70 to minus 55 millivolts. So what are the values? Minus 70 to minus 55 millivolts. Okay. Now remember, minus 55 is firing level. So what is that? It is firing level and voltage gated sodium channels open. Which gate? M gate open. Sodium come and cause a depolarization. So this is the depolarization because of voltage gated sodium channel till you reach a spike. So spike is the value. Now, so the spike is reached. Now once the membrane reaches spike, sodium channel close, H gate closes, depolarization is over, and now potassium channel open and potassium goes out, membrane return to RMP. So this word return is for re. So return is re. So return to the RMP is what? Repolarization. So what the return is? Return is our repolarization. Are you clear? Okay. Next question. The sodium potassium pump. What does sodium potassium pump do? So basically sodium potassium pump is for what? It pump 3 sodium out and bring 2 potassium in. That means it restore the ionic equilibrium after AP. After AP. Why? Because in AP sodium come inside, it throw the sodium out and bring the potassium in. That's why it help in AP and RMP both. So RMP, AP both. We need which help? We need the help of sodium potassium pump. Okay. Now memory is stored in the synapses of our neocortex neuron. Okay. And when you repeat a stimulus again, the neurotransmitter and the receptors are increased. This causes the memory formation called as synaptic plasticity. So what is the synapses? They are not fixed. They are not rigid. They can be changed. They can be modified. So this change modification of synapses is called as what? Synaptic plasticity is there. Okay. So synaptic plasticity is the case. Okay. Fine. Now next question. Long-term potentiation is when the NMDA receptors of glutamate are increased by hippocampus CA1 neuron. ये एग्जाम में आ रहा है आपका. And it causes conversion of short-term into long-term memory. And where is the long-term memory stored? It is stored in neocortex. It's stored in the neocortex. Okay. Now sensory system has 3 parts. First is the receptors. So what is the first part? It is our receptors. What do receptors do? So first question, receptors basically do what? Okay. So cortex. So receptor make the AP from the stimulus. Pathway take the APs to the cortex, and once they reach the cortex, the cortical centers are responsible for perception and memory. So what they are responsible for? They are responsible for our perception and the memory. So what is for perception and memory? Our cortical center. So what they are causing? Perception and the memory. So perception and the memory is the case. Are you clear? So is it clear? So perception and memory. Next is what else do we also see, discuss or have? So we'll discuss. First is the receptors property. First is threshold. What is threshold? How much stimulus we need to give to get the response, like hearing. Minimum hearing threshold is 20 Hz. So we can't hear a sound less than 20 Hz. Then we have specificity, that is receptor respond mainly to their type of stimulus. So that is our specificity. So it is receptor don't respond to any stimulus, they respond mainly to their specific stimulus, like light only rods and cones, hearing cochlea, that is called as specificity. Then if you give a stimulus continuously, you feel less, like smell. When you go to a place, garden, शुरू में smell आ रही होती है, after some time the sensation of smell reduces. What is the reason? The receptors there will adapt and you can't smell it any longer. Now if you have slow adapting, you can sense longer, so sensation persists longer. This is our slow adapting sense. And non-adapting, the pain is felt all the time till healing occurs. That's why pain is non-adapting. It doesn't stop, it continues all the time till healing takes place. Lastly, we have is the Weber-Fechner law and Stephen-Power law. So which law? Stephen-Power's law. In this case, the intensity of the sensation is proportional to the stimulus to the power A. A is power. So it becomes something like this. I is K S to the power A, where K is a constant. Okay. Next question. Spatial sense, vision. So vision has basically three main property. First, receptors are rods and cones, okay, and pathways, optic pathway, and the area is 17, 18, 19. For color vision, V4 and parvocellular pathway. This can be exam question. Parvocellular pathway. Done. So that is for our vision. Okay. Now dark. Dark is our rhodopsin. So what is dark is? Dark is rhodopsin. It is 11 cis. तो याद करना, in night time sister डर जाती है, तो याद करना sister डर जाती है अंधेरे से. So that's why sis बहन डर गई. क्या ना, बहन डर गई, बहन डर गई, बहन किस डर गई? काले रात में डर गई. Because of this. Now when the light falls, light cause a transformation. So light cause a transformation. Or sometime you are going, so when you put the headlight, let's say you are going on your bike or car, you see a sister standing near the traffic signal, you see it's a sister, you want to help, but that might be a transgender. So that's why याद कर लो, light पढ़ने पे transgender भी दिख सकता है आपको, अंधेरे में पता नहीं था ना. So that is trans. So remember, trans is light, ta for trans. Okay. Next question is, it lead to closure of sodium channel. So lead to closure of what? Sodium channel by transducin, which is a G protein. So what is transducin? It's a G protein. This produce hyperpolarization of all other receptors do D. So what is the only one causing hyper? Rods and cones. Okay, rods and cones causes the hyperpolarization. Okay, all other receptors causes depolarization. Others. Okay, only rods and cones cause the hyperpolarization. Others cause depolarization. Okay, now we'll discuss auditory system. Auditory system, it is inner hair cell at the organ of Corti in the cochlea, which cause the hearing. Second, potassium is very high in the endolymph and that create endolymphatic potential. MCQ, it can be asked. How much? Plus 85 to plus 100 millivolt. Okay, so plus 85 to plus 100 millivolt. Okay. then potassium channel open and create our CMP, cochlear microphonic potential. Okay, so what channel open? Potassium channel open in the inner hair cell and cause which current? Cochlear microphonic potentials. Next question, auditory pathway mnemonic is colema, which is colema is cochlear nerve and nucleus, olivary, like superior olivary nucleus. L is for lateral lemniscus, I is for inferior colliculus, M is for medial geniculate body, and A is auditory cortex. So A is auditory cortex. Lastly, auditory cortex area is 41 and 42. Finally, superior temporal gyrus, the area is 22. It is the vernix area for language. Okay, so it is the vernix area for language. And finally, angular gyrus is area 39 for word memory. So what is the area 39 for word memory? It is angular gyrus. So it is our angular gyrus. Okay, now question आया था आपका, if there is a lesion of Wernicke's, it causes sensory lesion, sensory fluent aphasia. A person can speak but not understand. This is sensory aphasia. Okay, and angular gyrus, it causes word blindness lesion. Word blindness. Next is taste. So taste is basically by what? The papilla of the tongue called as taste buds. Now remember, fun कहाँ होता है? आगे. So in school also remember, fun कहाँ होता रहता है? आगे, टिप पे. And foliate is side. तो याद करना, fun मजा कहाँ है? आगे, टिप पे होता है. Foliate is on the lateral margin. Circumvallate is back. So late comer in the school also sit where? At the back. So they are at the back. Okay. Now remember one more thing. Salty flavor is due to salt is sodium and potassium. What is sour? Sour is acid. Sour is acid. Sweet is due to our G protein coupled receptor sugars. Okay. Glucose. Okay. Saccharin. Then bitter is poisons. Bitter is poisons. So poisons cause bitter like cyanide, alkaloid, all the drugs and drugs. Next question, umami. Umami is very addictive and it is triggering the sensation via binding to the receptor. What substance? Monosodium glutamate, which is present as Ajinomoto. Or meat, protein, egg, pulses, they all contain Ajinomoto. Egg, pulses, all, etc. So whenever you eat something which contain your glutamate or glutamine, it give you umami flavor. That's why people love meat, egg, pulses, soybean, all. Lastly, for this, so remember, in school, which kind of children used to sit in the front? So tip is sweet. So sweet बच्चे आगे बैठते थे, they'll be licking teachers boot licker. चाटते रहते पूरे चाटू बच्चे. ओके, और दे विल इरिटेट द स्टूडेंट्स एट द बैक एंड द बैक वाले क्या बोलते हैं? अबे क्या दिमाग खराब कर रखा तुम लोगों ने. सो दे आर बिटर. सो बिटर इज बैक. सो क्या बोलते थे? नीम का पत्ता कड़वा, ये आगे वाले कड़वे, बहुत तंग कर रहे हैं तो पीछे वाले कड़वा है. सो बैक इज बिटर एंड आगे कौन है? स्वीट. नाउ उमामी इज इन द मिडल. माँ बीच में आती है. So ma is in middle. So where is mother? Mother is in the middle. Sar is back laterally. So it is back and lateral side. Back lateral. Salty is sides. Salty is sides. So what is on the sides? Salty, but actually it's a wrong diagram. Reason? You can actually feel all sensation in the tip itself. Okay, chalo. Now next question. Chili is not a taste but pain sensation. That's why if someone say I love chili flavor, you say no, you're not loving the chili, you love chili the pain. तो आपको pain पसंद है, you love the pain and you are eating chili giving yourself the pain, that make you a sadomasochist. You like the pain also, you like the pleasure also. That's the case. Second is it contain capsaicin. What it contain? It contain capsaicin and it bind vanilloid receptor. So remember chili, capsicum, याद है capsaicin. And what you ask someone to eat when they eat chili by mistake, कि भाई आइसक्रीम खा ले vanilla. So vanilloid receptor, also called as TRPV4. Second, if chili is a pain sensation, where can you feel the chili sensation? Any part of body. That is why if you eat too much chili, you feel burning in the mouth, and next day morning also you can feel the burning, because your anal canal region again contain the receptors for chili. That's why it's a torture method where they insert chilies into rectum of the victim. क्या बोलते हैं इसे? Anyone? What is inserting chili in the rectum called as? क्या बोलते हैं? किसी के पिछवाड़े में आपने चिली डाला तो उसको क्या बोलोगे? Anyone? What is the term? Anyone? Yes, Bellari. It is called as Bellari. So Bellari is inserting chili in the anus. सही है? तो क्या है? Bellari. चलो. Now come somatosensory system. So what system? Somatosensory. Okay. कोई नहीं. Bellari I taught in forensic. Now, first question. The sensations from body like pain, temperature, touch, they are called as somatosensory. Now receptors are first Merkel disc in epidermis for sustained touch and pressure, and also 2-point discrimination, which is best at fingertips and lips. What distance? 1 to 2 millimeter distance also we can detect. And remember, it is not Meissner's corpuscles for 2-point discrimination. For 2-point discrimination, the best is Merkel. So please, I am requesting you, don't ask me again. If I say 2-point discrimination is best at fingertips and lips, it is Merkel disc. It's the Merkel disc. Okay. Now, Meissner. Meissner is at the tip of dermal papilla. So the location, tip of dermal papilla. We have the Meissner's corpuscles, and they are for fine touch and low frequency vibration. So fine touch and low frequency vibration. Then come Pacinian, anion. They are onion shape. So if they give a receptor which look like an onion, it is Pacinian. So Pacinian look like onion, and they are for high frequency vibration and also pressure. So high frequency vibration and pressure is the funda. So high frequency vibration and pressure is by Pacinian corpuscle. So what is that? It is our Pacinian corpuscles. Okay. Ruffini is for warmth and actually sustained pressure. Sustained pressure. Then Krauss and bulb. It is for cold. Okay. Remove sustained pressure. Just keep cold. It is for cold. And remember, cold is when temperature is what? Less than 25 degree. MCQ. And less than 10 degree, pain is there. So if your skin is exposed to temperature below 25, like AC 25, you feel this bit, like chilly weather. Okay. But if it is below 10, you start feeling pain. Example, if you ever pick a ice box in your hand, after few seconds you start feeling burning and pain. What is the reason? Below 10 degree, the Krauss and bulb fire and cause a paradoxical pain response. Why? Earlier they were make you feel cold. Now they causes the feeling of the pain. Now comes the next question. Free nerve endings, they are basically for pain, temperature, itching and sexual sensation. So what is for pain, temperature, itching, etc.? Free nerve endings. Now, pain is of two types. What are the two types? Fast pain, slow pain. Fast pain is carried by A delta myelinated nerve fiber, whereas C unmyelinated autonomic nerve carry the slow. From which area? Example, angina, colicky pain, headache, etc. So all of these are carried by autonomic nerve from the viscera, That's why it's called as visceral deep pain. So any organ injury inside the body is the visceral pain. And who carry the visceral pain? C fiber. Okay, and it is dull and diffuse. It is what in nature? Dull and diffuse. Also it can show radiation. So which pain can show radiation? Angina or even colicky pain. Example, angina radiate to the left arm, which I discussed already in medicine class, called as Levine sign, chest, and a fist is over the chest all. And remember, skin injury is an example of fast pain. It is sharp, well localized, also called as superficial or somatic pain. Next question. What are the ascending tract? Let me just make a simple diagram to explain to you. Okay, so let's start. So this is our spinal cord. Okay, so this is the gray matter. This is dorsal column. This is DC, dorsal column, DC. So dorsal column is at the back side in the white matter. This DC. It carry fine touch, pressure, vibration, proprioception, stereognosis. Now what is stereognosis? If we asked in the recent exam, what is stereognosis? So stereognosis is identifying the object by touch, is called as stereognosis. What is it called as? Stereognosis. Also graphesthesia. Now what is graphesthesia? आओ देखते हैं. So graphesthesia is if you can recognize the letters written on the skin without seeing, it is called as graphesthesia. Now lateral spinothalamic tract carry pain and temperature. याद करना lateral, लात. If someone kick you, किसी ने लात मारी तो क्या होगा? Pain. So lateral is pain. Lateral is pain. And anterior, ant is for what? चींटी. क्या करती है? Itching, चींची, चींटी, itching, चींची. So ant causes itching. So ant causes itching. So remember, ये बना रहा हूं मैं चींटी. देख रहे हो चींटी, चींटी. तो क्या करती है चींटी? It look something else, but जो भी है, चींटी causes the itching and crude. Now where is the sensory cortex? It is in post central gyrus parietal lobe. Parietal lobe. So post central gyrus in the parietal lobe. Second, the primary area is 312, secondary area is 5 and 7. Maximum area in sensory homunculus is for face, lips, hand, thumb. Face, lips, hand is thumb. You can see. So hand is very big. I'll just color them. So it is very big. The hand, the thumb is very big. Okay, and lips. So these two are the largest area, lips and thumb. So that is called as your homunculus. Are you clear? Okay. Now let's see motor cortex. Let's see. So this is okay. It's up to you. Okay. ठीक है. ठीक है. Is life, easy life. ठीक है. अपना काम है पढ़ाना. चलो ये frontal, temporal, occipital, parietal. So this area which I am shading and giving the yellow color, this is motor cortex. So what is motor cortex? This is the area 4 and 6. So area 4 and 6 is the motor cortex. It is in pre-central gyrus. Pre-central gyrus. Pre-central gyrus is there. Okay. Second, it contains bed cells which are upper motor, and they give a tract called as corticospinal tract or pyramidal tract. I've discussed it very well in medicine class also. They give the fibers which are CST 85 to 90% cross at lower end of medulla pyramids. That's why it's called as pyramidal tract. What is called as PT, pyramidal tract. And the pyramidal tract help in voluntary fine skilled movement like writing, drawing right now, and it stimulate the alpha motor neurons. What is stimulate? It stimulate the motor neurons. Motor neurons. And once it stimulate the motor neurons, it causes the movement. So that is by releasing acetylcholine. So release the ACH, stimulate alpha motor neuron and causes the contraction. And the alpha motor neuron give the motor nerve which causes the contraction. So remember, upper motor control the lower motor, which are spinal cord neurons, via extrapyramidal and pyramidal tract. So if there's a tract lesion, the upper motor can't control the lower motor. So it causes high tone, high reflexes, high resistance of the muscle. But what is there? There is a spastic paralysis. And if there's a lower motor lesion, it causes flaccid paralysis because muscle will lose all contraction. Why? Decreased tone, decreased reflexes. So decreased tone is flaccid paralysis. So decreased tone is flaccid paralysis. Now remember, muscle length is sensed and regulated by spindle. Spindle. So spindle is for length. Remember the mnemonic spindle, length, le. So length ke liye. And tendon, tension. So tendon, tension. And it causes stretch reflex. It causes what reflex? It causes the inverse stretch reflex. Okay. Now muscle spindle causes stretch reflex, which is also called as deep tendon reflex, like knee jerk, ankle jerk, bicep jerk. First, the length is sensed by spindle. Then they stimulate alpha motor neuron to cause the contraction and the muscle go back to normal. So this contraction after striking the tendon is called as the deep tendon reflex. Okay. Now remember, there's a neuron called as gamma motor neuron. What do gamma motor neuron do? They cause muscle tone. What's a muscle tone? It's a continuous muscle contraction produced by our gamma. And tone help in balance posture. Tone help in balance posture gait. So balance, posture and gait. And basal ganglia cause planning of the movement and also control tone and control tone. And cerebellum is for coordination and correction. Lesion causes ataxia. Here the lesion cause Parkinson, etc., which we have discussed in medicine class. Okay. Now remember, emotions are produced by limbic system. By limbic system, example, our first example, happiness, pleasure. Pleasure by dopamine. Ventral tegmentum. And fear, dar, atank. Fear by amygdala. So fear is produced by amygdala. So what causes the fear? Amygdala produces the fear. So what causes the fear? Amygdala. Okay. And who control them? The thinking and control of emotion is done by frontal lobe. So what make us, like control our emotions? बहुत गुस्सा मारू. Like your senior or your parents abuse you. What want you to beat your, not parents, okay, beat your seniors? Answer is frontal lobe. But why you're not slapping your senior resident, your boss? The answer is frontal lobe. क्या बोलता है? कंट्रोल, उदय कंट्रोल. सो कौन कंट्रोल कराता है? फ्रंटल लोब कंट्रोल कराएगा. आर यू क्लियर? नाउ व्हाट आर द मेन फंक्शन ऑफ हाइपोथैलेमिक न्यूरॉन? सो सुप्राऑप्टिक is basically for ADH. So supraoptic is ADH, also thirst. So thirst center or thirst is this. Paraventricular is again for ADH, but it is mainly for oxytocin. Okay. Also it releases three hormones, TRH, which increase the TSH. Then it releases CRH, which release the ACTH. and also it play a role in the stress, that is CRH. Okay, so and also oxytocin. Then suprachiasmatic is for circadian rhythm. Asked in the last exam, circadian rhythm and pineal gland. What it releases? It releases melatonin in dark. So melatonin in dark. So it releases melatonin in dark. Which cause sleep induction. That is why sleep is better with light clothes. Then come arcuate. What is the story about the arcuate? It is for stimulation of growth hormone. So it's for what stimulation? Growth hormone stimulation. Now comes the question, regulation of pituitary gonadotrophin. So regulation of pituitary gonadotrophins is the one which is basically, so I'll just write here, it releases basically GHRH, increased growth hormone. Then GnRH, which increase LHFSH. Then increases our PIF, which decreases prolactin. So decreases the prolactin. Okay, that is the case. Also appetite, but main function are these. Now periventricular or PVN. It is basically for inhibition of growth hormone. So PVN is for decreased growth hormone. So decreases growth hormone. Then come ventromedial. Ventromedial is our satiety center and also growth hormone. So also growth hormone. So growth hormone and satiety, and it is stimulated by leptin and MSH. They decrease the hunger. So who decrease the hunger? It is by our leptin and alpha MSH. MCQ. Dorsomedial is again basically for feeding, help in feeding, but it is basically for multiple action. You can skip it. Now lateral is hunger center, and who stimulate the hunger center? Orexins. Ghrelin, neuropeptide Y also increase sympathetic. Increase the sympathetic. Okay. Then preoptic is the third center. It induce the drinking. So induce the drinking and also help in male sexual behavior. So preoptic is for sexual behavior and also thirst. Anterior cause cooling of the body, cool the body. Posterior warm the body. Very simple. So what cause cooling? Thanda karta hai. Anterior. So remember air conditioner. What does air conditioner do? It cause cooling of the body. So yaad kar lo, AC cool karta hai, and behind the AC the compressor warms the body. So याद करो, आगे से ठंडा करेगा, पीछे से गर्म. Now remember, first change, first is skin. So the first change in hot weather is skin vasodilation and our sweating. Sweating is absent in heat stroke. Very commonly asked question, heat stroke. और टेम्परेचर क्या है इसका? 40 डिग्री. So if the temperature is above 40 degree, sweating is absent, suspect heat stroke. Okay. PDF is already there in the description. You can click it, Shruti, and you will get the link of Google Drive in the description. Just click the description. Okay. Now posterior cause the heating. So it causes heating of the body, warm the body. First change is again skin vasoconstriction. So skin become constricted. Then also it causes piloerections. What it causes? Piloerection. And also there is shivering, which is absent in newborn. So that's why newborn uses non-shivering thermogenesis by brown fat in children. But remember, brown fat is absent in the adult. 100% exam question, don't ever ignore it. Okay. Now lastly, what are the EEG changes? So remember, a awake person show beta wave. So which wave? Beta wave is seen in awake. Frequency is 14 to 30 hertz. What is the frequency? 14 to 30 hertz. And if the eyes close, alpha wave comes. So remember, eye open, beta wave, eye open, beta wave. If you close the eye close is alpha wave, 8 to 13. So remember, eye open, beta, eye close, alpha. Then stage 1 NREM, you see alpha and theta wave. So alpha and theta wave. Theta wave is 4 to 7 hertz. So the frequency 4 to 7. So 4 to 7 theta seen in light sleep, which is stage 1 NREM. Stage 1 NREM. In stage 2, we have light sleep is the longest sleep stage. Also, we see sleep spindle and K complexes. So what is seen here? Sleep spindle and our K complexes. So it's very, very important. Ask in the exam. So I'll highlight it. So sleep spindle, K complex. So this is the sleep spindle and I'll make it K complex. So this is K complex. So this is K complex. Look like a K. This is spindle. Then in the deep sleep, we get delta wave. So deep is delta. Deep is delta. In delta, what is going to happen? So in delta, deep, stage 3 NREM, deep sleep. Delta wave are seen. Delta wave frequency is 0 to 3 hertz. What frequency? 0 to 3 hertz. And they are very big in size. And there is night terror. What is night terror? Unknown fear. So if a person is seeing a dream and he cannot remember, this is called as night terror. And also bedwetting and sleepwalking. What do they occur in? They occur in the NREM sleep. Now we'll discuss REM. Very good, Dr. Abhijit. Now what about the REM? Remember. So in REM, the person can remember the dream. So REM is remember. Memory is formed. Also we get sawtooth beta wave in the REM. Sawtooth beta wave. Can you see this? Also nightmare occur. What is nightmare? Fearful dream. So remember, if you can remember the dream, it is called as nightmare. If you can't remember, night terror. Also there is a sleep paralysis. So EMG give you a flat line. So EMG give a flat line. This was the exam question. So with sleep, the EMG is going to give you a flat line, sleep paralysis. It is our REM sleep. So this was INI-CT 9th May. This year exam question. They gave a graph. Eyes were showing the movement and the brain was showing the sawtooth and flat line in the EMG. The answer is REM sleep. So with this, we'll end up our entire physiology we have covered, and you will get surely 8 to 10 MCQs from this without any fail. So I will upload this in the group. You watch it. So I have 9 PM important meeting. So I will take this and then I'll meet other. So medicine I will not be taking because we need 3 hours. So it will not be possible. So we'll take it tomorrow. Tomorrow we do medicine, and after medicine we start with other system. Okay. So we'll start 6 PM and take till 11. Okay. 5 hours class tomorrow. Okay. Chalo. Take care. Bye bye. I'm ending the session. Thank you very much for coming. Take care. Bye bye.